Yes, I'm Linda Lord. I'm going to be presenting All in the Family, a multidisciplinary approach to drug-nutrient interactions. And what I did is I presented the nursing perspective at the American Society for Parenteral and Enteral Nutrition, their 2021 Nutrition and Science Practice Conference. We just had that virtually in March of this year. And I'm happy to present it again here at the Oley 2021 virtual experience. I have no commercial relationships to disclose. So I'm going to be using cartoon characters and made-up scenarios to cover these learning objectives. So Miss Jeju Nowport, she's going to help us list the requirements of an order for medication delivery to make sure that it's complete for the ones that are going through the feeding tube, and also explain the importance of the patient education. Mr. Melvin Mixer, he's going to lead us through describing the appropriate administration of multiple medications through a feeding tube. Most patients usually are getting more than one. And then Miss Paula Purified, she's going to very most carefully discuss the dilution and the water type to be used for medication delivery through a feeding tube. So the first scenario here is patient Jeju Nowport. That's sort of telling us it's a jejunal port, which is a small bowel feeding port. And she's a aspiring, but then she turned aspirating actress. And she developed a very severe idiopathic, which means it's an unknown etiology, gastroparesis, which is delayed stomach emptying. And they've tried some prokinetic agents on her. These are medications that get the stomach to contract and the little pyloric valve between the stomach and the intestine to relax, to hopefully push food down. But she was non-responsive to these medications. So over time, she was able to tolerate less and less food going into her stomach because of the gastroparesis. And it was determined that she was only meeting 20% of her caloric and protein needs. So she was losing weight. And then eventually she couldn't even get fluids to empty from her stomach to her intestine. So she was becoming dehydrated. So they brought her into the hospital and they tried a small bowel tube feeding. So what they did in the hospital is they put a tube down her nose and fed it down into her small bowel and did a drip tube feeding through a feeding pump, and she tolerated them just fine. So she had no motility problems in her intestine. It was just isolated to her stomach. So after that was successful, they decided to send her to interventional radiology, and she had what's called a GJ tube placed. So I'm going to go over this very carefully. GJ stands for gastric jejunal. You know, in the medical world, we abbreviate everything. So this has a tube, which is one tube, as you can see here, but because this is a balloon GJ tube, there's actually 3 different lumens all going within one tube. So this part here is, and going out like this, is what the patient will actually see. The rest of this is inside the patient. So here's the balloon port. So these all 3 exit at different points. So the balloon port is the smallest lumen, and that goes all the way down into the stomach, and it blows up a big water balloon outside the tube. So this prevents the tube from dislodging from the stomach. These all have these external, what they call bolsters or discs or phalanges. There's no accepted description of it. People kind of use their own term for this. And this here is pushed down. So this is kind of a one size fits all, because once you get the tube in, you push this down and make it even with the outside of the abdomen. So it's the pressure between this balloon and this phalange or disc or whatever you're going to call it, that will keep this all in position. So the balloon prevents the tube from coming out. This phalange or disc prevents the tube from going in too far. So the second one here is the jejunal port. This is the second largest lumen, and this is the long one. So this one goes all the way down through the stomach, down into the small bowel, and it has exit points here. So most people who have GJ tubes will have tube feedings in their small bowel here so that they don't aspirate the tube feeding formula, and their water flushes. The third port here is the gastric, which just goes into the stomach. This is the biggest lumen, and this one will end right about here. There's a bunch of holes right there, right in the stomach. So if someone's getting a small bowel tube feeding through the jejunal port, then many times they'll get their medications through the gastric port and maybe a little bit of water to flush the medicines down. So that maybe hopefully the stomach will have enough emptying to at least get the medications into the body, but the majority of the tube feeding and the water will be given down below. So they place this tube in jejunal port, and she was started on a tube feeding. Now with small bowel tube feedings, you can't give bolus nutrition because it's a long tube that has to have a very slow drip in order for the formula to be absorbed. It's not like the stomach, which is a big reservoir that can hold feedings in for a while and pass it into the small bowel. The small bowel is a long tube that's just there for absorption, and it has to be given very slowly with a drip. Otherwise, you have stomach or intestinal cramping and diarrhea. So in addition to the pump tube feeding, she was hooked up to an automatic flush pump. So what they have nowadays is that you have one bag with your feeding formula. You can have a secondary bag with water in it, and it pumps water through every hour. And for her, they were just giving her 10 cc's, but that's enough to flush the tubes so that you have less chance of sludge buildup and clogging of your tube. I tend to order these with most people who are on pump tube feedings, especially in the small bowel with these long jejunal tubes, because they're very thin and they can clog very easily. With that, she was also ordered a 30 milliliter, which is 1 ounce of water flush before she started the tube feedings and a water flush after. And then again, these 10 cc's every hour while it was infusing. So everything looks good so far. So everything was going great. And then she developed Gerd, which is gastroesophageal reflux disease. So her provider decided to order her what they call a proton pump inhibitor, and this blocks gastric acid in the stomach. So the provider ordered a delayed release Omeprazole capsule, 40 milligrams daily in the morning. Open the capsule, dilute the contents in 20 milliliters of water, and give via the feeding tube. So this is what Jeju saw. She said, okay, well, I'm giving my tube feedings in my J port, so I guess I should give this medication through my J port also. And okay, I'll give it in the morning. So my tube feedings go all night. Most people who have small bowel tube feedings infuse them overnight, so they're free of tubing during the day. And she said, okay, I'll give this Omeprazole immediately after my overnight tube feeding. Well, there's multiple things wrong with this scenario, at least 6 things wrong. So first off, the order did not identify whether to give the medication via the G port or the J port. It just said give via the feeding tube. So the patient just had to guess where to put it, and she just decided to put it in the J port. Well, most medications are studied giving them in the stomach, not the small bowel. The stomach has acids in it. The small bowel tends to be more alkaline. There's just a lot of differences between the two. And for the most part, you're always going to try to give medications in the stomach as much as possible. Second of all, delayed release medication should never be given via feeding tubes. So delayed release medications tend to have these enteric coatings on them that are meant to dissolve at various points of the GI tract. So medications are released early, and then some of it's released later, so you have some sustained effects of the medications that you're giving. If you crush these delayed release medications and give them immediately, you're going to get too high of a dose of medication early on and then nothing later. So any medication given through a feeding tube must be immediate release medications. You might have to give them more frequently throughout the day, but you can never give delayed release medications through a feeding tube. Now, for example, Omeprazole does have immediate release powder for oral suspension, so that is available. Again, number 3, omeprazole contains capsules. You know, even if you open it up, there's enteric coated granules in there. So those granules, they will disperse in water, but they do not dissolve. So if you try to put those granules through the J tube, it most likely will clog it. Number 4, Jeju was not educated on the delivery of this medication via her feeding tube. Not only was it missing a lot of things and was an error, you know, nobody really talked to her about it and educated her on it. And there's more things to know about medications, which I'll get into a little bit later. Medications via feeding tube should have a 15 to 30 cc water flush before and after. And why this was an error is that that wasn't stated in the order. And Jeju decided that I'm going to give my tube feedings and then I'll follow it with the omeprazole. She didn't think about putting a water flush in between. And now you're going to have tube feeding formula and medication in this Jeju port, and they're going to mix with each other. And sometimes medications can make things precipitate out of formulas, and you can form a big clog there very easily. And I should let you know that clogs that form within feeding tubes, if it's just the formula that's causing the clog, those clogs might be able to be opened up with some of the things that are out there, like warm water flushes or pancreatic enzymes that you add like sodium bicarbonate to, all these different solutions to open clogs. Medication clogs have no solution. I mean, there's nothing out there that really can dissolve a medication like it can dissolve a feeding formula. So you really need to try to prevent medication clogs as much as possible, or otherwise the whole tube's going to have to be replaced. And then number 6, tube feeding should be held for at least 1 hour before and 1 hour after omeprazole administration. So this is particular to that medication. So that should have been stated in the order and educated to Jeju port so that she knew that she should wait 1 hour after her tube feeding was done before she gave the omeprazole. So now we have scenario number 2. This is patient Melvin Mixer. So Melvin here was receiving multiple medications through his feeding tube, and then he suffered a stroke. And I'm sorry, I gotta move this over a little bit. Oh, he was receiving multiple medications when he suffered a stroke. So he was getting a lot of medicines. All of a sudden he developed dysphagia, and they put a G tube in so that he could have some tube feedings to keep him nourished and hydrated. So when he was in the hospital, all of his medications were converted to either immediately release tablets, which is good, that were crushed and diluted in sterile water, or they were in liquid form so that they could be given through the G tube. Now the nurses took all these medicines and they mixed them together within a 60 milliliter flush syringe. They flushed this G tube with 30 cc's of water before, put the 60 cc water flush with all the medications mixed together in after, and then flushed it again with 30 milliliters of water. Now, many nurses will say, why not mix the medications together and deliver via flush syringe? I mean, they all end up in the stomach anyway, so what's the difference? Well, if you talk to any pharmacist, they will tell you that if you put these liquid or these diluted powder medications in direct contact with each other within this 60 cc flush syringe, you can have interactions that take place. And what they say is that you're making a new mystery medication because it can interfere with the really good therapeutic effect of each medicine. And then also sometimes they can interact with each other and form a clog. So when they do go into the stomach, you know, the stomach again is a big pouch, a big reservoir with lots of fluid and stuff, and you don't have that direct contact. So that's the big difference. Now, when Melvin Mixer was discharged, his home caregivers went a step further. They said, well, why don't we just add all his medications to the tube feeding bag? Why not add medications to the tube feedings? After all, they all end up in the stomach. Well, this is what could very easily happen. So you add your medications to the tube feeding bag and things can happen. The proteins can precipitate out of the formula and things can separate out. And would you really want to put this into your stomach? So the thing is that, and I know it's hard for people to hear this and nurses to hear it or patients at home, but in order to get the full therapeutic effect of each medication that you have, you really need to administer each one separately with at least, and these are the guidelines, a minimum of 15 cc water flush in between each one. Now, I'm not saying that if medications are being mixed together that there are going to be interactions, but if you think about it, there's so many thousands of medications out there. It's just not possible for people to study this and mix different medicines together and see what happens. So because that's not being done, the recommendation is to administer each medication separately. So scenario number 3 is Paula Purified. So Paula was hospitalized and she developed seizures. So they started a phenytoin suspension. This is an anti-seizure medication. And it was ordered to be delivered via her nasally placed 8 French feeding tube. So French is a diameter of a tube. Most tubes that go down the nose are usually 8 or 10, maybe 12 French at the biggest, versus feeding tubes that go into the stomach or intestines. So G tubes who go into the stomach, they're usually anywhere from 16 to 24 French. So their diameters are much bigger and they're very short tubes, whereas tubes that go down the nose have smaller diameters and they're very long. So it naturally, the tubes that go down the nose are a higher risk for clogging. So this suspension is very thick. And so her nurse tried to administer the suspension directly through this long, small bore tube, but it was very viscous and some of the medication was lost. So the nurse is thinking, what is the best way to administer this medication? And the nurse started researching it. So first of all, medications that go through the tube, they have to be diluted enough to ensure that the medication delivery is all the way through to the distal end of the tube and to the patient. If you look up phenytoin, the suspension that's very thick, only 10% of it is delivered to the patient if it is not diluted or flushed. So a general rule of thumb is to dilute suspensions 1-to-1 with purified water, followed by a flush of the same total volume. So if you have 10 cc's of a medications, you should add 10 cc's of water and then followed by a flush of the same total volume. But like I said earlier, you should always flush the tubes with at least 15 cc's of water. So that should be the minimum to flush the medication through the tube. Okay, I mentioned purified water twice. What is purified water? I mean, I saw this too, and I had to look this up and research it because purified water, what does that mean? So this is the definition of purified water that's all throughout our nutrition support literature. It's water that is free of contaminants. So this is chemical and biological, following source water selection, distillation, and filtration. Well, layman's term, please. I even needed to ask, what does that mean? So I talked with a lot of the pharmacists that are part of our organization, and drinking water, like tap water, bottled water, well water, they can be used for hydration purposes and they're just fine. They contain minerals and things, like tap water has fluoride in it. Those things are great. You know, you can use them to flush your feeding tubes. But they may contain chemical contaminants and therefore increase the risk for potential medication interactions. So whatever's in your tap water or bottled water can interact with your medications and actually alter the medication bioavailability of what you're putting in. And bioavailability is the effect of the medication. Like, you want to have the full effect of your medications. So what does that mean further? So what is purified water? what do we use for home? So in the hospital settings, we use sterile water for irrigation. It's purified water, but it is not necessary for the diluent to be sterile. The sterile water generally is not covered by insurances, so we don't order it for patients for home. But for home use, distilled water may be used. So that's a great thing. You can get a jug of distilled water. It's going to be purified water because there's going to be no minerals or contaminants, chemical contaminants in there. And this is the water that we recommend that you use to dilute your medications and further to do your 15 cc water flush before and after each of your medications. So again, this is what's recommended nationally for medication delivery through feeding tubes to get the full bioavailability and the full effect of the medications that you're taking. So Paula Purified says, thank you for keeping me so pure. So I do have, I do have a few minutes left, so we can talk about some learning assessment questions. So I'd like you to look at these three. I've got the answers on the next page. I'm going to give you a few minutes and see if you can correctly identify the answer to each of these questions. I can read them out loud too. Which of the following is not a necessary element of an order for medication to be delivered through a feeding tube? So which one is not necessary? Whether it is through the gastric feeding tube port or the jejunal feeding tube port, is that necessary? How much water to dilute the medication in, is that necessary? Which of the current medications can this medication be mixed with? And D, the dose and frequency of administration. So which one of these is not necessary element of an order for medication delivery? Question number 2. Again, which of the following is not a necessary question to ask when opening up a capsule and administering the contents through a feeding tube? Are the contents immediate release or delayed release? B, should a water flush be delivered before and after the medication delivery? C, what solutions should the contents be diluted in, and how long do they take to dissolve? Would that be a question you would ask? D, should the medication be delivered in the stomach or the small bowel? And then number 3, in the home setting, which of the following is the safest and most economical, both of those, solution to dilute a medication? Distilled water, spring water, sterile water, or tap water? Okay, so these are the correct answers to those questions. So number 1, which of the following is not a necessary element of an order for a medication to be delivered through a feeding tube is which of the current medications can it be mixed with? Because as I mentioned to you before, we don't know what medications can be mixed together and be okay, because we didn't study them all. We didn't study these three medications mixed with that medication. So don't mix the medications together is what's advised. Number 2, which of the following is not a necessary question to ask when opening up a capsule and administering the contents through a feeding tube? Should a water flush be delivered before and after medication delivery? That's not a question because water flushes should always be delivered before and after medication delivery. And like I said, at least 15 milliliters of water, either sterile or distilled water is advised around medication delivery. And then in the home setting, we just reviewed this. Which of the following is the safest and most economical solution to dilute a medication? And it's distilled water. Sterile water is safe, but it's not the most economical solution. These are different references that I used to for this presentation here and the guidelines that are out there. And then all of our little characters are now smiling because we've answered all their questions and hopefully things are going along fine. So that's the end of my presentation, and I think we'll be available for questions a little bit later.
Thanks so much, Linda. We have a couple of questions that I think we have a few minutes that we should be able to address them now. I know it's out of sequence, but some are specific to the things that you've addressed. So I'm going to throw you a couple if you don't mind.
No, that's fine.
Amanda asks, as a home health registered dietitian, I see many patients on PPIs who are giving them via feeding tube. Unfortunately, in Canada, only the standard enteric coated capsules are covered under pharmacare, not the powdered suspension. Do you have any suggestions on how to give it more safely?
Yeah, when I get to those points, I do actually call the pharmacist of the pharmacy that the patient is using for recommendations. I know it is difficult because you do try to order liquid medications, and many times the insurances won't cover them. But there are different, like there are quite a few PPIs out there, and again, I would just defer to the experts, and whatever pharmacy that they're using, I would call the pharmacist directly and tell them of your dilemma, and that's what they get paid the big bucks for.
Thanks. Amanda also asks, do you suggest holding feeds for 1 hour for all PPIs?
No, I would, each one is individual, so I would look up each one. Actually, there is a book that's, I thought I have it in another room here, but it's by Joe Bellotta, and it came out 2 years ago, and it's all about enteral medication delivery through feeding tubes. I know it's on the ASMN website, and so that might be a good reference for you to look up individual ones. Or again, if you want general guidelines for all the medicines, but you can always, again, call your local pharmacist.
Thank you. We also have a question from, well, it's kind of a question, kind of a statement. The trouble with giving medication separately is that, well, I'm going to give you two. They're kind of related, but not exactly the same question. And both of them are from consumers. The trouble with giving medication separately is it adds so much more volume, and many of my patients can't tolerate the volume. I guess that's tumor. And then also in a related comment, Melissa says, I totally understand the reasoning behind the medication flushing guidelines. But in reality, inpatient or outpatient, getting a number of meds QID whilst also needing to be on continuous feeds 22 hours per day simply isn't practical. There aren't enough hours. Sorry, I can't. There aren't enough hours in the day. How do we find a happy medium, or how can we access a knowledgeable pharmacist to hash out the top priorities?
Yeah, and I know in the hospital settings, I know the nurses do mix the medicines together. As far as overloading with too much fluid, I mean, there are more concentrated tube feedings out there. So if you feel like you're giving too much fluid with your medication, sometimes you can consider a more calorically dense tube feeding formula, because there'll be less water in the tube feeding. So that might help you out. And I don't know the answer to the time element of things. All I can say is that this is the, national guidelines. And I know the pharmacists are the ones that help us out with that, but it's the nurses that actually deliver the medications, and the patients at home that have to give it. When I see patients in clinic, I give them these guidelines. Some of them will switch immediately and do everything, completely appropriate or to the guidelines that are out there. And then there are others who have mixed their medications together. They feel like they're getting a good effect of their medicines. They have not seen anything in there that shows that anything's precipitating out or clogging their tubes. And then they'll just continue doing the same thing. So I guess that's the best advice I can give, is you should educate your patients, help them out as much as possible to make sure they're getting the appropriate amount of fluid. Yeah, of course, you don't want to give them too much fluid if they're restricted, and you just might have to consider very minimal water flushes and then maybe calorically dense formula. So typically what I do is I tell them, 30 cc's minimum water before and after the tube feedings. If they're on a pump, I tend to use the automatic flush pump. I might only give 10 cc's every hour. And then with the medications, the minimum amount to dilute them and get them through the tube, and then add it all together. If that doesn't work, try to use a calorically dense formula.
Thanks, Linda. And did you have any thoughts on contacting a knowledgeable pharmacist about prioritizing, you know, maybe?
Yeah, I always feel like the pharmacists might be underused. So I contact the pharmacist in our institution continuously with questions like that. Instead of trying to research it myself, I contact the pharmacist, I tell them about the dilemma, and they get back to me. I think in the outpatient setting, these pharmacists at these pharmaceuticals are doing medications all day. I would think that it would be interesting for them for you to approach them with a dilemma and have them figure it out, because they are highly educated. I know here in the States, you have to have a PhD. So I don't feel bad at all with contacting my local pharmacist and working with them as a team, to try to figure these things out.
That's a great point. Whenever we have to go to somebody to ask a question, the pharmacists tend to, I agree, they enjoy the challenge and figuring it out. Thank you so much. They're great comments, and sorry, great comments in chat, and we look forward to having you join us for the Q&A.
You're welcome. Thank you for asking me to present today.
It was a wonderful presentation.